say that after this wonderful talk by Professor Manchanda, the enigma is no more an enigma. We have really been able to solve the mystery quite a bit. And now we will go ahead and take this discussion forward with the help of our eminent panelists. I'm sorry, this was the name of panelist that was given to me earlier, and this has changed a bit. So we have Professor Kishore Khatri here from Pathology Department of SNMC. We have Dr. Gopal Bora from AIIMS Jodhpur. We have Dr. Nirupma Kothari, who is a pathologist here in Jodhpur, and Dr. Pradeep Reddy from PGI Chandigarh. So let's go ahead and we will probably delve a little more into the techniques that are there now in the field of Waldenstrom diagnosis. But as ma'am has already stressed that the peripheral blood is the most important thing, so I'm very happy that our beginning will be with that of the peripheral blood. So we start with the first case, that of a 61-year-old gentleman who presented with generalized weakness for 6 months. He had mild hepatosplenomegaly, but there was no lymphadenopathy as such, and the patient came to us with an outside report that there was an M-band positive. Right. So when the peripheral blood came to us, this was what we saw. So you can clearly see all of us that there are these RBCs that are stacked on top of each other. So this is definitely a formation here. If we take a closer look, this is how the CBC was. The patient had anemia, hemoglobin of 8.7. The platelets were slightly more. The TLC was normal, 9,000. There was a slight lymphocytosis of 45% with the neutrophils being 42%. And we could see some of these kind of cells which look like plasmacytoid cells maybe on the peripheral blood on the background of this Rouleau formation. So based on this peripheral blood morphology findings, let me go to the clinicians first. Dr. Bohra, what would you say your DDs are, and to resolve those DDs, what test would you want to further order?
The open case at this point of time. Rouleau formation will suggest many things from hyperthermoproteinemia to hemolytic anemias. But I think at this point of time we will like more of clinical history, and with clinical history, level of inflammatory markers, ESR, AG reversal, everything else we will be liking. Before going on for tests like bone marrow biopsy and other things, I think that first of all we should have a clear-cut clinical output followed by the routine testing, and then we should be going for biopsy and other tests.
Right. What about Dr. Reddy? What do you think?
Yeah, definitely with the lymphocytosis, hepatosplenomegaly, and M-band positivity, we definitely think of lymphoplasmacytoid leukemia, particularly with the Rouleau formation, the biomarker. So we'll do our IgM immunofixation assay and IG profile. If that is positive or whatever it may be, bone marrow is a must.
Right, right. So all these tests were done, and IgM paraprotein was found in this patient, and then we went ahead and did the bone marrow examination. So I'll come to the bone marrow examination. Now you can see that the bone marrow showed a particulate and hypercellular bone marrow. You can see that these clotted particles are present, so there was a slight hemodilution of this bone marrow. But when we look at the cells, you can see that there are these lymphocytes which are slightly increased here. Some of these lymphocytes with these thin arrows are showing eccentrically placed nuclei, maybe some increased amount of cytoplasm, again plasmacytoid lymphocytes maybe, and then there are some of these clearly plasma cell kind of cells. So we have a mixture of lymphocytes, plasmacytoid lymphocytes and plasma cells. This is the aspirate which are slightly diluted. We go ahead to the imprints and we see that the imprints is really full of all these lymphoid cells. We did a differential count and we saw that the lymphocytes are around 60% and the plasma cells are around 5%. We can also see a mast cell here, and we'll come to the relevance later. Of course, we have discussed about this. So we did the biopsy as well, and we can in the biopsy you can see this is a nodular aggregate that is being appreciated. We take a closer look. You can see all these lymphoid cells a little away from the trabeculae in a nodular pattern. So there are lymphoid nodules in the bone marrow. There is increased lymphocytes and prominence of plasma cells in the bone marrow aspirate. So there is definitely a possibility of bone marrow infiltration in this patient. So now we need to see the characterize what these lymphoid cells are, right? And to further characterize them, what are the tests that you would need to do? So Dr. Khatri, if you would want to
Yes, there is a nodular aggregate of lymphoplasmacytic cells in the bone marrow. Diagnosis of non-Hodgkin's lymphoma is expected. Now we confirm is the antigenic nature of these cells, so we need to do immunophenotyping and flow cytometry. So in that case, mature B cell lymphoma can be brought our differential. Then immunophenotyping for all those four categories as Madam has mentioned in the last lecture. Then to reach a diagnosis, we need as serum protein and some routine tests like CBC, hemoglobin, platelet count and all, then liver function test, renal function test, EG ratio. We need then serum protein electrophoresis is needed to identify whether it is a monoclonal or polyclonal. Then the class of immunoglobulin we also need to label some. Then various panels which can be used for these mature B cell CD19, we can go for first CD45, then CD3 or CD20 for differentiate between T and B cells. Then we can go for CD19, 20, 22, 23, 25, 27. Then we can go for even CD56, CD28, CD103, CD138. So there is a whole list of panel, list of antibodies that will differentiate the permutation combination of the positivity and negativity will reach us to a certain diagnosis.
Okay, so what we basically have is that to know the nature of these cells, you need to do immunophenotyping, right? And immunophenotyping is probably by two ways. Either you do an IHC on the bone marrow, or a more simpler way, if you have a flow cytometer, then do a flow cytometry for the cells, right? So, and we also discussed about the panels of antibodies that you want to use here, right? So, this is the kind of panel that we have in PGI. We have two B cell tubes which have the light chain restriction markers, kappa and lambda. We have B cell markers like 19, 20, 38 and 45, etc. We also have other markers like CD5 and CD10. After that, we also have a T tube, of course. And if something like a hairy cell comes up, we also have a hairy cell tube where we can put further markers for hairy cell leukemia. Okay, so in this case, what we did was, because the B cell lymphomas are much more common than the T cell lymphomas, initially we get the B cells. So this is how we do a flow cytometry experiment. Initially, we see all the continuous events in the forward scatter versus time plot. Then we rule out the doublets and look at the singlets only in the forward scatter peak versus the forward scatter area plot. And then we take out the viable cells by removing all cells which are smaller in size compared to the lymphocytes. And what we found that there were around 30% CD19 positive cells. But 30% CD19 positive cells is really large number of cells. We'll get these many B cells in the bone marrow. So we further went ahead and saw that these blue CD19 positive cells are positive for both CD20 and 45. So they are probably mature B cells because they are not CD45 dim. They are negative for CD5 and CD10. They have a variable expression of CD38, all the CD20 positive cells, and a variable expression of CD200. And when we look at the light chain expression, they are all kappa restricted, so they are clonal B cells. Right. So if we go ahead, how can B cell, mature B cell neoplasms be classified on the basis of flow cytometric immunophenotyping? Dr. Nirupama, would you like to take this question, please?
The differentials which come into the B cell neoplasms are the splenic marginal zone lymphomas, mantle zone lymphomas, and the B cell lymphomas. So we need to differentiate on the basis of the markers which are coming positive, and of course the lymph nodes have also given biopsy in these cases because they will be associated with either lymphadenopathy or splenomegaly. In this case, there was no lymphadenopathy.
No lymphadenopathy.
So if there was splenomegaly, the things which come into picture are the marginal zone lymphomas and the splenic mantle zone lymphomas and the splenic marginal zone lymphomas.
Right.
So on the basis of the long list of the markers which we have already discussed, we can easily differentiate the kind of B cell lymphoma VRS and added to that the light chain restriction which is found in Waldenström's.
Absolutely. So I think we have to look at the panel of markers that we are, and of course B cell lymphoid neoplasms on flow cytometry. First thing, as you rightly said, is identification of light chain restriction, and then looking for the aberrant antigen expression. So based on aberrant antigen expression, two very important aberrant antigens to look for in B cell lymphoma, CD5 and CD10, and based on these we can classify mature B cell lymphomas. So CD5 positive and 10 negatives are mainly mantle cell and CLL. CD5 negative 10 positives are the Burkitt's follicular DLBCLs. And the category of 5 negative and 10 negative is where we are interested now because our case was 5 negative, 10 negative. We have hairy cell leukemias, marginal zone B cell lymphomas, and lymphoplasmacytic lymphomas, right? So there is also a rare category of 5 positive, 10 positive where we get rare lymphomas, but let's look at that category at the moment. So where we are standing is here, we have CD5 negative, 10 negative. The morphology was not like hairy cell leukemia, and let's assume that the hairy cell markers were also negative in this case. So now the main two differentials that we are left with are marginal zone B cell lymphoma and hairy cell, and LPL or Waldenstrom. So now, can we differentiate LPL and Waldenstrom from marginal zone lymphoma by flow cytometry? Is there any technique? Because we know that both of them are CD5 and CD10 dual negative. So are there any markers that can help differentiate these two? Dr. Khatri, maybe if you can.
LPL cell will be CD25 positive and CD103 negative. And the reverse is for systemic marginal zone lymphoma.
That's right.
Then some mutational analysis or translocations can help if you can.
Right. I think basic drift is that it's very, very difficult to differentiate based on the markers that we have usually available. There are some new markers that have come up. This is a study that was there in our department using CD148 and CD180. And we could characterize 148 and 180, and using these we can differentiate between the LPLs. So CD180 MFI, high MFI of CD180 showed 100% sensitivity and 90% sensitivity for diagnosis of marginal zone lymphoma, whereas the higher 48/80 ratio was more in favor of an LPL. So, but the problem is that 148 and 80 are not markers that are available everywhere. There are studies about CD13 expression as well, but again, these are not really used much. Here the cutoff that they used was 2%, so 2% is too low a cutoff to be used in flow cytometry. So I think what we have here is that it's very difficult to diagnose, differentiate these two entities on flow cytometry. Now, when we looked at the flow, there was this population which was 20 positive and which was 5 and 10 dual negative, but there was also this population which was 38 bright positive and 20 negative in this, and there seemed to be a continuation between these two. So what are these? These are basically the plasma cells that are there in this case. So plasma cells are there, these are 20 negative, 38 bright. So is there any difference in the immunophenotype of plasma cells in LPL versus what we get in multiple myeloma? Can we on the basis of flow, differentiate the myeloma plasma cells from the LPL plasma cells? Dr. Khatri, would you like to?
Plasma cells in LPL or Waldenstrom's, they are basically shows combination of T cell and plasma cell numbers, like 19, 20, 22, and 10. They are, and the pure plasma cells are CD138 positive, and even sometimes CD38 positive can also be seen. While pure plasma cells, they are usually not 19, 20 positive. Even CD45 can be seen dim positive, but in lymphoplasmacytic lymphoma, CD45 will be good bright positive.
Right. And there are some other markers as well. So if you look at this table here, there are these different antigens which are expressed in plasma cells. For example, CD19 is present normally in normal plasma cells, whereas it is negative in abnormal plasma cells. 56 and 117 are negative in the normal plasma cells, whereas they are strongly positive in the abnormal plasma cells, and so on and so forth for the multiple myeloma. Now, in our case, what we had was we had this 38, 138 positive plasma cells. They were positive for CD19 and 45. They were positive for 27, negative for 56, negative for 117, negative for 56, and their kappa chain was restricted. So this is the kind of pattern that we see in LPLs, where the plasma cells do not have any aberrant expression of markers, but they are definitely light chain restricted. If we take a case of multiple myeloma, we follow these 138 and 38 positive cells, there are some green cells and some red cells. The red cells are the abnormal myeloma cells. They will show you abnormal expression of CD117, CD56, also down regulation of 19, 45, etc., along with the light chain restriction. So this is how we differentiate the plasma cells of LPL versus plasma cells of myelomas, that they don't really express aberrant markers. The plasma cells of LPLs don't express aberrant markers, but still are light chain restricted, whereas the plasma cell of multiple myeloma are expressing aberrant markers as well. Right. So in this case, we have presence of clonal B lymphocytes, presence of clonal plasma cells, and morphology probably like an LPL or Waldenstrom. So now the differential still remains marginal zone versus LPL, because we know that marginal zone lymphoma can at times have a very marked plasmacytic differentiation, and it becomes very difficult to differentiate these two entities. So after flow and morphology, is there any other clue that you would like to see to differentiate, help differentiate between these two entities? Maybe Dr. Bohra can highlight on this.
I think now the role of molecular comes for P88 mutation analysis in this case.
Right, that is absolutely
There are others also, but we will first like to look for them.
for mediated mutation. I think that's the right approach. But as ma'am highlighted, they could LPL mutations could come in marginal zone as well. But there are only rare marginal zones which show mediated positivity. So yes, you're right. We have to do molecular testing. And as you rightly said, the most common mutation in LPL is the mediated mutation, which we did not really know till around 10-12 years back. But in 2012, this was the first paper which came in MEGM that showed that MID88 was present in nearly 90% of all Waldenstrom's patients. And several studies have now confirmed that it is present in more than 90% of Waldenstrom, and it is absent in patients with myeloma, including the IgM myelomas. It is less frequently found in, as we discussed, marginal zone lymphomas, also in CLL. So therefore, this is definitely going to help. So if we go to Dr. Khatri, what are the methods of detecting MID88 mutations?
You can go for fish.
Fish would be a little difficult for MID88 mutation analysis.
Then ASO quantitative ESR, then allele specific oligonucleotide. Quantitative PCR can be done.
Okay.
Then NGS latest is there, cellular sequencing that can be little over.
But what are you want to add to it?
I think that has been already asked, right from whole genome sequencing to NGS to pyrosequencing. So all of these methods can be used for a variety.
Right. But so in a small molecular lab where you don't do a sequencing, maybe we have to understand that MID88 L265P mutation is actually a point mutation. So since it's a point mutation, we can do simple PCRs like an RFLP PCR or an ARMS PCR. These are very simple tests, not very difficult to standardize as well. So that is what we can do. But the latest guidelines are also saying that we should have a sensitivity of at least 0.1%. That makes it very difficult for us to catch these tests using a PCR RFLP or an ARMS PCR. So this probably explains why in a lot of centers which are using ARMS PCR or a PCR RFLP, we are not getting as high an MID88 mutation levels as we would expect. Like in our institute also, we are probably getting somewhere around 60-70%. We should get around more than 90%. So this is probably one of the reasons. So in that era, we should have to go for a higher, more sensitive techniques like digital PCR, ASO, quantitative PCR, and sequencing. Now, if you are talking about sequencing, we have to remember that sequencing has to be done in CD19 sorted cells, because otherwise we're getting the DNA from all different kinds of cells of the bone marrow, and our sensitivity will again go down. So if we immunomagnetically sort out the CD19 positive cells and then do a sequencing, our sensitivity will probably increase. Right. So this was the publication from our department, which did RFLP PCR. This is basically the negative control where we get only a single band, a positive control where because of the restriction digestion we get 3 bands, and this was our case where we had the MID88 L265 mutation because we saw 3 bands here. Right. Other than that, of course, we can also have non-L265P mediated mutations, and NGS, of course, is a very good technique to look for these mutations because now we have to sequence. Problem, of course, is that NGS is not widespread and Sanger does not really have that sensitivity. Its sensitivity is around 20%, so difficult. So, other mutations in LPL or Waldenstrom, Pradeep? We have discussed about the MID88 mutations. Any other mutations you want to? Yes. So we have CXCR4 mutations. So this was a study in 2014 which first revealed that other than the MID88, we also have the BIM-like CXCR4 mutations that are really present in approximately 30 to 40% of Waldenstrom patients. And this has a whole list of other mutations that can be seen by a whole genome testing in LPLs or Waldenstroms. Right. So, Dr. Bohra, could you say if there are any therapeutic implications of these mutations in Waldenstrom? I think we have discussed this already in the previous year. Yes. But so if we have, let's just go ahead and we'll see that there are these mutations can cause resistance to treatment like ibrutinib and other agents that can be used. This was the paper that came out in 2014, as early as 2014. and even later trials have shown that the response and survival are poorer in patients having these CXCR4 mutations. So current guidelines are probably suggesting that if you can go ahead and do a mutation, it is probably a good idea to go ahead and do a CXCR4 mutation analysis in these patients. So there are now a thing that I would like to highlight here. Professor Manchanda was telling us that if we have a paratrabecular infiltration, it is most likely not Waldenstrom, but there are a couple of papers now where you are differentiating LPLs from marginal zone lymphomas. They have shown that in the differential diagnosis of these two entities, having a paratrabecular infiltration probably favors a Waldenstrom more than a marginal zone, because the frequency of paratrabecular is even lesser in marginal zone lymphoma compared to a Waldenstrom macroleukemia. Other than that, of course, we have presence of LPL cells, Dutcher bodies, increased number of mast cells already highlighted, and mediated mutations. Right. So if we go ahead from this case and come to a second case, this was a very interesting case that we had a 67-year-old gentleman presented with proteinuria, deranged RFT, dyspnea, pedal edema. Outside, bone marrow had 12% plasma cells and an M-band was positive, and bone marrow was done at our center, of course, at the moment to rule out multiple myeloma. So this was what we saw. We could not see any ruler formation here. There was again mild hemoglobin, mild anemia, platelets again mildly increased, TLC normal, differentials normal, nothing much in the peripheral blood. Bone marrow was normal cellular and showed some pinkish material here. This was the bone marrow imprint smears, again showing increased lymphocytes, and we can see these dark cells which are as highlighted mast cells. A lot of increase in mast cells in this picture in the bone marrow imprint smears. So plasma cells were around 9%, lymphocytes were around 24%, not very high. Flow cytometry showed 5 negative, 10 negative Pachovi cells and 1.8% lambda restricted plasma cells. So these features are all sensitive towards LPL on flow as well as morphology. So with that background, should we know what is the diagnostic criteria for LPL actually at the, currently, and are there any new changes in the latest classification systems? If Dr. Nirupama could talk about the diagnostic criteria for LPL or Waldenstrom's. What all do you need for a diagnosis? No, so let's recapitulate what we have discussed here.
So first we look at the number of lymphoplasmacytic cells in the man.
Yes, great.
So there are criteria, different criteria. Some people say less than, more than 10% lymphoplasmacytic clonal cells in the man.
Right.
Along with that, the IgM levels in the protein electrophoresis and an NTM band, and the value of the band should be more than 30.
Right.
And then along with that, the clinical symptoms are also there to add on to the our diagnostic range. And this is coming into the lymphoplasmacytic and not into the lymphomas. Myelomas. And
Do you think there's a role of immunophenotyping as well in the
of
diagnostic?
course, light chain restriction actually, immunophenotyping and the light chain restriction is very important to shift our diagnosis towards LPL.
Right. So I think you are absolutely right here. This is what the WHO, the latest WHO classification 2022 states that there is an essential criteria and desirable criteria. The essential criteria is that the significant bone marrow infiltration should be there. So there we only use the term significant here. And this is the infiltration by clonal plasma cells, lymphocytes or plasmacytoid cells and or plasma cells with the immunophenotype of the LPL cells. That is, as ma'am highlighted, IgM positivity, 19, 20, 22 positivity, 5 negativity, 10 negativity, 25 positivity and 103 negativity. The desirable criteria include the mediated and CXCR4 mutations as well as the serum electrophoresis and immunofixation. Of course, we need a comprehensive approach and we need all these tests to make the exact diagnosis, but this is how WHO 2022 describes it. And the other classification system that came out in the year 2022 was the International Consensus Classification, which were the people who had earlier written the WHO. So they have said, they have actually added something here. They have said that abnormal lymphoplasmacytic aggregates are required in the bone marrow to call it LPL. These aggregates might be present in less than 10% of the bone marrow, but aggregates should be present in the bone marrow to call it an LPL. And it is strongly encouraged mediated and CXCR4 mutation. They also subclassified IgM MGUS into the IgM MGUS plasma cell type, which are the precursor of the very rare IgM multiple myelomas, and the IgM MGUS NOS, which are basically the precursors of the LPL and can harbor the mutated mutations. Right. So if we go back to this case, this was the bone marrow biopsy in this case, and we really don't see any lymphoid aggregates here, right? But because we had those clonal plasma cells, we did IHC. IHC showed slightly increased CD20, also increased CD138. So we had increased plasma cells, we had increased mature B cells, and then we saw that there was this thick-walled vessel kind of thing here in the bone marrow. So what do you think here now after looking at this? Yes. So,
Highlight material in the wall of some highlight material amyloid in the wall of this.
absolutely, absolutely. So this is probably what is happening to this patient. There is something there in this wall, and we went ahead and did a Congo-Red stain. I'm not sure if it is visible here, but under plain polarized light, we saw these apple green birefringence in this patient, and there was definitely amyloid deposition in the blood vessels. So now we come to this question. We know that amyloid deposition is very often associated with multiple myeloma. Can amyloid deposition also be associated with LPL? Dr. Bohra, maybe.
We have one similar case
Okay.
admitted which was proteinuria for us.
Right.
Inner enrollment, significant proteinuria.
Right.
Then we went for the Congo-Red stain and it came positive. So only one case I have seen, so it can happen.
Yes. Pradeep, do you have any experience?
Yeah. We recently diagnosed a case of IgM and hepatitis. So they usually have renal involvement as opposed to cardiac involvement with plasma cell clone. The clones are different and therapies are different. So with a plasma cell clone, obviously you body-based therapy VCD, DARA-VCD, and with a LPL clone, you will obviously give BDR or RCDs.
Right. Okay. So I think that is absolutely right. So this is review on the light chain amyloidosis associated with Waldenstrom's that was published in Hematologica in the year 2023. And here also you can see the rarity because they had study was conducted in 2006 and 22, and they had only 49 patients of Waldenstrom with AL amyloidosis. So it is really a very rare entity. Here 20% of the patients, that is 20% of 49, 10 patients had a simultaneous diagnosis, and in the remaining 39 patients, AL amyloidosis was diagnosed after Waldenstrom, that is subsequently, with the median age of duration was, interval was 3 months. And you can see that the occurrence of Waldenstrom amyloidosis confers a worse prognosis in Waldenstrom patients, and the management, of course, as you rightly said, is really not standardized that much for this. Right. So now here we come to the question is how do we classify Waldenstrom and related disorders? Now, Pradeep, could you take this? I think in this context, based on the clinical presentations, do you have any different classification?
IgM and this molding
Yes.
Waldenstrom's
Right.
and clinically symptomatic disorders.
Right. Dr. Khatri, would you